Good evening, everybody. Today's subject seminar class is on anatomy and physiology of breast. Um, I was going through latest articles about the anatomy and physiology, and to my surprise, there is not much that has changed since we all studied anatomy and physiology. Of course, you don't expect much to change, but the way of looking at anatomy and physiology has also not changed much. So that's why I was actually not pleasantly, but surprised about that. And so Praveen will share with us his thoughts and knowledge about anatomy and physiology of the breast. Over to you, Praveen.
Yes, sir. Good evening to everyone. Today we'll be seeing the aspects of anatomy and physiology of breast. Breast or mammary gland is a modified sweat gland which forms a secondary sexual feature of female, and it is a source of nutrition to neonate, but it is rudimentary form in males. Breast is situated at superficial fascia of pectoral region. It can be divided into four quadrants as upper middle, upper lateral, lower lateral. A small extension of upper lateral quadrant, which is called as axillary tail of Spence, passes through opening in the deep fascia called as foramen of Langer through this region. And the breast lies vertically from second to sixth rib and horizontally from lateral border of sternum to mid-axillary line. When compared to deep relations, breast lies on the deep fascia, that is pectoral fascia covering the pectoralis major muscle. Deep to the deep fascia, the pectoralis major muscle, serratus anterior, external oblique muscle of abdomen. Breast is separated from the pectoral fascia by loose areolar tissue, which is known as retromammary space, and this space allows the breast to move freely over this pectoralis major muscle. Coming to structure of breast, let's see the nipple, which projects from the center of breast anteriorly. Its shape and projection varies from cylindrical and rounded at top to hemispherical to flattened depending on the hormonal and developmental factors. Nipple usually lies at the fourth intercostal space in the midclavicular line. It is positioned 20 to 23 centimeters from suprasternal notch in midclavicular line and 20 to 23 centimeter apart in horizontal plane. It contains circular and longitudinal smooth muscle fibers, and these fibers make the nipple stiff or flattened respectively. And nipple is pierced by about 15 to 20 lactiferous ducts. The pigmented skin surrounding the base of nipple is known as areola, and it contains numerous modified sebaceous glands, particularly in the outer margin. It enlarges during the pregnancy and lactation, and it is known as Montgomery tubercles. It secretes oily secretions which lubricates the nipple and areola, and it prevents cracking during the lactation. The skin of nipple and areola is devoid of hair follicles, but it is rich in melanocytes. Coming to parenchyma of breast, it consists of compound tubulo-alveolar gland that consists of about 15 to 20 lobes. Each lobe is a cluster of alveoli, and it is drained by lactiferous ducts which converges towards the nipple and open on the superior surface of nipple. Near the termination of the lactiferous ducts, each duct has a dilation, that is lactiferous sinus. And the passage of milk from alveoli into and along the ducts are facilitated by the contraction of myepitheliocytes. Here we can see the each lobule, and in the breast it consists of around 15 to lobules, and from each lobule there is a lactiferous ducts, and at the end of lactiferous ducts we can see the lactiferous sinuses that open into the nipple. Stroma mainly consists of supporting framework of gland, which is partly fibrous and partly fatty. Fibrous stroma forms the suspensory ligaments of Cooper, and this anchors the skin and gland to the pectoral fascia. Fatty stroma forms main bulk of the gland and is distributed all over the breast, except beneath areola and nipple. Coming to blood supply, arterial supply is mainly in the laterally by the axillary artery and its branches of superior thoracic, thoracoacromial, and lateral thoracic. Medially by branches from internal thoracic artery, and which is a branch of subclavian artery. And it also gets supply from second to fourth intercostal arteries via the perforating branches. Normally, the venous drainage, venous follows the arteries. It converges towards the base of nipple and forms an anastomotic venous circle and runs in two sets. That is, superficial veins drain into internal thoracic vein and superficial veins of lower part of neck, while deep veins drain into axillary and posterior intercostal veins. The breast is mainly innervated by anterior and lateral branches of 4th to 6th intercostal nerves, which carry sensory and sympathetic efferent fibers. Nipple is also supplied from anterior branch of lateral cutaneous branch of T4, and it forms an extensive plexus within the nipple. The sensory fibers of nipple terminate close to epithelium as free endings, mucinous corpuscles, and mercal disc endings, which is essential in signaling the suckling sensation to the central nervous system. The secretory activities of gland is largely controlled by the ovarian and hypophyseal hormones rather than by the efferent motor fibers. Lymphatic drainage can be seen into lymph nodes and lymphatic vessels. Lymph nodes, it mainly consists of axillary lymph nodes, which can be divided into groups such as anterior pectoral group, posterior group, lateral, central, apical, and interpectoral or Rotter's lymph node. The other lymph nodes includes parasternal nodes, and sometimes lymph drain into supraclavicular nodes, cephalic nodes, posterior intercostal nodes. Among these nodes, 70% of lymph drains into the axillary nodes, 20% into the internal mammary nodes, and 5% into the posterior intercostal nodes. Based on the pectoralis minor muscle, axillary lymph can be divided into level 1, that is lateral to pectoralis minor, level 2, located deep to the pectoralis minor, and level 3, medial to pectoralis minor. Lymphatic vessels includes superficial lymphatics, which drain the skin over the breast except for nipple and areola. These lymphatics pass radially to surrounding lymph nodes, that is axillary, internal mammary, and supraclavicular nodes. Deep lymphatics drain parenchyma of breast, nipple, and areola. While coming into the breast histology, here we can see the duct, and this is the lobule. And in between the interlobule, this is the interlobular stroma. From the lobe, when you can see the cut section of acinus, it mainly consists of basement membrane, myoepithelial cells, luminal cells. And this is main cell types of breast consists of luminal cells, and its function is milk production. And the myoepithelial cells, it supports a basement membrane, and it maintains the luminal cell polarity, and it is main essential for the contraction of milk ejection. In the mammography, this is the craniocaudal view, first picture, and here we can see the heterogeneously dense appearance. In the young females, the most of the breast continuous of it contains fibrous stroma, so the mammography it appears as dense appearance. But in the later senescence age, the breast mainly consists of fatty tissue, and the appearance it converts into radiolucent appearance.
Okay,
While
stop here.
coming, yes, sir.
Stop here now. Nikita? Hello? Hello, Nikita? Anybody else? Anybody else there? Any questions so far with respect to anatomy? Hello?
Yes, sir. Nothing to add.
No, sir. Nothing, sir.
So all of you are clear about the anatomy so far.
Yes, sir.
Lakshman sir, any questions
Yes,
sir
sir.
so far?
Nothing really. Are you touching on embryology later?
Yeah, embryology will come later.
Coming later. Okay, that's fine.
Yes.
Okay, I think you have covered the anatomy well. So I think there is one thing that I wanted to add. Though you are almost correct saying that the lymphatic drainage usually 70% goes to the axillary nodes and 30% to the internal mammary group. There is a significant amount of overlap also. So you don't have to be surprised if, for example, the upper medial and lower medial tumors spread to the axilla, and also the lateral tumor spread to the internal mammary also. But generally, it follows the pattern that you suggested. So that is one
Yes.
thing you have to be aware of, because in
Yes,
the
sir.
rarer instances, it can go to the internal mammary group also. So that is one thing you have to be aware of.
Yes, sir.
Apart from this overlap, is there any other mechanism where you can have this kind of relatively unusual drainage? Praveen?
Sir, not exactly, I don't know, sir.
All right.
Anybody else in the
Anybody
class?
else? Pavan,
Abdul.
Indraja?
Abdul, Sania, Abdul. I think you guys should know this.
Yeah. It is the blockage
And,
of lymphatics, blockage of the conventional channels by tumor emboli. So when that happens, there is a retrograde flow of the other tumor cells, and they can end up in unusual areas of drainage. Okay, that's pretty common for many cancers.
Okay.
Okay,
So
all right.
you have to be aware
Yes,
of
sir.
it. Okay.
Any idea which part of the breast drains into axillary and internal
Gen-
mammary and posterior intercostal?
Generally, the pattern is that the upper outer and the lower outer quadrants, the nipple areola complex, all of these are believed about 70% of the breast believed to drain to the axillary nodes. The upper inner quadrant and the lower inner quadrant is supposedly drains to the internal mammary. But as sir said, that this pattern can be disrupted by tumor emboli, blocking the lymphatics and then causing backflow also. So that is that is generally the accepted pattern. Srikanth, any other questions?
That's all.
The other nerve that he forgot to mention is the intercostobrachial nerve. Apart from the nerves that come from the intercostal nerves 2 to 6, but the intercostobrachial nerve, where does intercostobrachial nerve come from, Abdul? Anybody else in the class? And what is its significance?
So thoracic plexus,
Speak out loudly.
so the intercostal nerve, sir, based in.
I think that is. Hello, Abdul, your line is not very clear.
Intercostal nerve, sir.
Yeah, but intercostobrachial nerve, which nerve does it come from?
Not sure, sir.
I think that is a homework for you guys. And what is its significance when you are doing mastectomy? Somebody said second.
Second intercostal nerve, sir.
Yeah, that is correct. That is correct. Second intercostal nerve. What is its significance?
Most commonly damaged in axillary dissection.
Not damaged, man. I think basically you are, to achieve oncology clearance, you actually voluntarily sacrifice it. What does it cause once you sacrifice it?
Numbness in the medial side.
Numbness of the skin over the axilla, which actually can be quite uncomfortable, but I think in the larger interest of oncologic clearance, that nerve is usually sacrificed. Right. Okay. I think that's much. I think that is about the anatomy. So go to the next part.
Coming to development of breast develops from an ectodermal thickening called the mammary ridge or milk line or line of skulls, extending from the axilla to groin.
It's called Schultz.
Schultz. Yes, sir. it is extending from the axilla to groin. The invagination of thoracic mammary bud occurs by day 49, and the remaining mammary line gets involutes. Nipple formation begins at day 56. Primitive ducts develop at 84th day, and canalization occurs at about 150th day. During the last 2 months of gestation, duct becomes canalized. Epidermis at the point of original development of gland forms a mammary pit into which the lactiferous tubules open. In about 90% of newborn will have breast secretion referred as witch's milk. This is because of the elevated maternal hormones and prolactin levels. And this is the line of Schulz. The common developmental anomalies are amastia, that is the absence of breast, athelia, that is the absence of nipple, and polymastia, that is supernumerary breast, which occurs in the line of Schulz, and polythelia, that is supernumerary nipples, and gynecomastia, that is development of breast in male. In the pre-puberty stage, the breast mainly composed of dense fibrous stroma, and there will be only little scattered ducts lined by epithelium. During the puberty stage, hormone-dependent maturation, that is tillage, includes the increased deposition of fat, formation of new ducts by branching and elongation, and first appearance of lobular units occurs. This stage is controlled by estrogen, progesterone, adrenal hormones, trophic effects of insulin, and thyroid hormones.
Good.
And you can see the stages from the pre-adolescent to the adult female.
So, Praveen, do you know which estrogen and among estrogen and progesterone, go back to your previous slide, which causes development of the ductal system and which causes the development of the lobular unit?
Sir, lobular unit is by the progesterone, sir.
Correct. And ductal unit is by the estrogen.
Estrogen, sir.
Subsequent, you are coming to the master, this one, no, pregnancy and all that?
Yes, sir. Next I will be coming,
Right.
sir.
Okay, right. Carry on.
During the pregnancy, the breast enlarges as ductal and lobular epithelium proliferates. The areolar skin darkens and the accessory areolar glands becomes prominent. In the first and second trimesters, the minor ducts branch and develop. During the third trimester, fat droplets accumulate in the alveolar epithelium and the colostrum fills the alveolar and ductal spaces. In the late pregnancy, prolactin stimulates the synthesis of milk fats and protein. After the delivery of placenta, the circulating estrogen and progesterone levels decrease, permitting the full expression of lactogenic action of prolactin. And milk production and release are controlled by the neural reflexes arcs that originate in the nerve endings of nipple areolar complex. Oxytocin release results from the auditory, visual, olfactory stimuli associated with the nursing, and it initiates contraction of myoepithelial cells, which results in the compression of alveoli and which results in the expulsion of milk. After the weaning of infant, the prolactin and oxytocin releases subsequently decreases, and the dormant milk causes the increased pressure within the ducts and alveoli, and it results in the atrophy of epithelium. During the menopause stage, there is a decrease in secretion of estrogen and progesterone by the ovaries, which results in the involution of ducts and alveoli of breast. The surrounding fibrous connective tissue increases in density, and slowly the breast tissues are replaced by the adipose tissue. And first picture represents the adolescence stage, and second is a pregnancy during which there is widely found ducts and alveoli, and third depicts the lactation stage, and final picture depicts the senescence stage where there is involution of ducts and alveoli.
Okay. So, Nikita, are you there? Is she on call or something? Praveen?
Sir?
Is Nikita on call?
Yes, sir. Yes, sir. Nikita is on call today.
Yes, sir. I'll just call her up, sir.
Okay. Abdul, looking at this picture, what is the significance of how would you investigate a patient when you are looking at some pathology in a patient who is young, who is pregnant, who is lactating, and who is, postmenopausal.
So post-menopausal, there will be involution of both the ductal and the lobular unit
Yeah,
with the shrinkage of the ducts and the lobular unit.
correct. Yeah,
And in puberty as well as in adolescence, there will be more proliferation of fibrous stroma, whereas in pregnancy, both fibrous as well as the ductal component proliferate.
right. All those things we know. Now, how
Yes.
would that influence your decision as to how you investigate these patients if they come with symptomatic breast disease?
Ultrasound for young ladies,
Yeah,
less than, whereas more than 40, we prefer mammogram.
not necessarily more than 40. I think postmenopausal, um,
I
you can
think,
use
yes,
mammogram. Though, you are right that around 40 to 45 is the menopausal age. So in that time, the fibrous stroma, the alveoli will shrink and the fatty. So any pathology in the background of fat will light up and, and is more obvious compared to, younger breast where the fatty component is less and the fibrous component is more.
yes.
Okay. So, Srikanth, any questions so far regarding the
Nothing. He has done well.
physiology?
Good.
Lakshman sir?
I had one or two things. He in the anatomy part, can I raise it now?
Yes, sir. Yes, sir.
Yeah. In the level 2 nodes, he defined level 1 as lateral to pectoralis minor, level 3 as medial, and level 2 as posterior to pectoralis minor. The Rotter's nodes are between the pectoralis major and pectoralis minor, which is anterior to pectoralis minor. So which group does it belong to?
Praveen?
Sir, I don't know, sir, exactly.
I still think it is level
Sir,
2.
yes,
It's
sir.
on either
Level
side
2.
of the pectoralis minor. Okay.
Minor.
So that
Yes, sir.
again would belong to level 2. And when he talked about the Cooper's ligament and the lymphatics and all that, he did not touch on the clinical significance of these, particularly
Applied anatomy.
Applied anatomy.
Yeah. So he has to
Yes, sir.
touch on that.
Pavan, are you there, Pavan?
Yes, sir.
What is the clinical significance of Cooper's ligament?
Sir, in case of malignancy, if there is infiltration of tumor cells
Yeah.
into the Cooper's ligament, there is a dimpling of the skin or puckering of skin will be there, sir.
Correct?
Correct?
What is the difference between tethering and fixation?
Sir, exactly fixation. The breast lump won't, sir. I don't know exactly, sir.
Okay. Indraja, do you know tethering and fix? Which is early, which is late? Indraja?
Yes, sir. Sir, actual tethering is because of the subdermal lymphatic, sir. Infiltration into the subdermal lymphatic.
Give me an example of tethering. If you tie a cow, to a pole and then the cow is free to move along the radius or the circumference of the entire circle that it describes. So the cow is tethered to the pole.
Yes.
So that is so in the early stages, the tumor probably, involves the Cooper's ligaments, not so much going all the way up to the skin. So the tumor is fixed, but along a certain circumference. As the the tumor develops further and infiltrates the Cooper's ligaments more, then it becomes fixed either to the skin and then causes puckering, or fixed to the pectoralis fascia and or the muscle. So that is fixity or the fixation of the tumor.
Yes, sir.
So that is the significance of the Cooper's ligament.
Yes, sir.
Okay, what about lymphatics? What happens? What's the clinical sign because of involvement of lymphatics?
PUD or insane, sir.
Yeah, that's it. So that has to be mentioned when you
Sir,
talk
actually,
about anatomy. Yeah.
yes, sir. Next class will be the same thing, same
No,
topic, sir. So
No, no, it is
whenever
benign.
anatomy and physiology are described, you
Yes, sir.
must have applied anatomy and applied physiology.
Physiology.
All right.
Okay,
So
sir.
when you
Yes,
talk
sir.
about
Yes,
the
sir.
activity of the breast and the activity of the hormones, for example, then you have to know what makes a neoplasm worse, what makes a neoplasm better in terms
Better.
of
Yes,
hormonal
sir.
fluctuation. And you must also
Yes, sir.
talk about, you don't have to go to the details, but you must also talk about the natural process of involution. Okay. And
Yes, sir.
mention about Andy, which of course will be described in detail in the next class. Okay, that is a part
Yes,
of,
sir.
because all the study of anatomy and physiology for surgeons must be applied. All right,
Yes,
my
sir.
final comment
Yes, sir.
that you listed a few congenital abnormalities and left out a couple. Can others sort of add to that list? You can even go back to that slide and then, yeah. Can you add to this list? Asymmetry is one. Okay. Asymmetry. Normally, both breasts are symmetrical, but as a part of a developmental anomaly, you can have asymmetry. And there is also a condition called macromasia, where the breast can be very big, okay, during the development, much bigger than usual. It has a clinical significance. Apart from the appearance, I'm not talking about cosmesis. What are the medical problems with macromasia? A very big breast. Yes.
Back pain.
Correct. Back pain, neck pain, and they have deep furrows, between the breasts and under the breast, and they can get eczematous rashes there. Okay.
And also psychologically, they can get
Psychologically, it's it has an emotional component to it as well. So these are the things that as surgeons you must know. Thank you.
Thank you, sir. And
Yes, sir.
Praveen,
Sir, yes, sir.
do you know if you said about the fibrostroma, the lobules and everything,
Yes, sir.
are all these distributed equally amongst the 4 quadrants of the breast? And what is the significance of that? When I ask that question, it obviously means it is not.
Yes, sir.
So the upper outer quadrant, the fibrous and fibrostroma and the lobular components are much more. Hence, the incidence of breast cancer is highest in the upper outer quadrant.
Upper outer quadrant. Yes, sir.
Okay, so you have to remember that.
Yes, sir.
Srikanth, anything to add? I also want Indraja. Indraja, can you?
No, not info is not required.
Huh? Indraja?
Yes, sir.
Can you describe the natural process, what happens to the breast in a normal menstrual cycle? And what is its significance?
Sir, during the menstruation, sir, that there will be cyclical mastalgia, sir, breast pain.
Yeah, that is later. You have to first
Yes.
describe what happens. What are the hormones that surge? What happens? in the proliferative phase, in the luteal phase, and then the involution phase.
Sir, initially progesterone will act.
No, not progesterone.
So, estrogen.
Not
First is
correct.
estrogen.
Estrogen, yes.
First is estrogen, that is from the onset of menstruation till the ovulation.
Ovulation.
So that is the proliferative phase. So there, what happens in the proliferative? The estrogen levels are high and causes the proliferation of the ductal epithelium.
Yes, sir.
And in the luteal phase, that is controlled by the progesterone. It prepares the breast for possible pregnancy. Okay?
Yes,
And
sir.
then at the, whenever the breast realizes that pregnancy has not happened, then it starts involuting. That is towards the end of that is before the onset of the menstruation. Just before the onset of menstruation. So this is the natural process, and hence, so you have, during the menstrual period, the cyclical mastalgia, increase in the discomfort and pain in the breast, because the breast becomes engorged during that time. And then as and when the breast realizes that it is not going to, that woman is not going to get pregnant, the edema and everything subsides, and then the pain goes away.
Finished his presentation, huh?
Ashte.
30 minutes we could have added applied anatomy, all those things, no?
Allah, ade, he is, I thought he said he will describe the applied anatomy, so I said, okay.
Applied anatomy takes another 15 minutes, that's all.
He didn't describe any of the, whatever sir has explained is only the applied anatomy now. Sir, we had McGregor. In McGregor, there was a lot of applied anatomy. Now, I don't think anybody consults McGregor at all.
McGregor and RJ last.
Lovely book. Lovely book.
Ade.
Fantastic book, McGregor.
All right. Okay. It's
So
good,
I think
good to have short classes at times also.
short classes. Actually, I think we could have combined this one also, benign breast disease also. I think it's okay. Yeah. So anybody else has any other explanations or queries or comments? Sania, you've been very silent.
No, sir, no question.
The registrars have to be more active. They must be
you
more
have
vocal.
And you have to
Ravi,
lead
I
the
think we
class.
should ask them to take classes. We'll just watch.
Ashte.
They should be mentors.
Correct.
All right.
If they are preparing for MCH entrance, they will ask questions.
Yeah, I think we should make them mentors at times.
Correct.
Okay.
Okay. I think if there are no other questions, we'll close the class. And I think tomorrow we have the benign breast disease. I think Sir Niranjan's father is still not
very
well.
Unwell, so we'll have to excuse him for a few days or whatever.
Yeah. Okay. Yes.
Whatever
okay,
length
sir.
of time it takes. Yeah.
Yes.
Okay.
Thank you,
All right.
sir.
Good night. I'll close the meeting.
Good night.
Nice.
Good night, sir. Thank you, Shrikant. Thank you, sir.
ಏನಕ್ಕಪ್ಪ ನೆನ್ನೆ ಬಂದಿಲ್ಲ?
Thank
Nani